Okay. All right. So welcome again, everyone. Although we are quite less today, I'm not sure, maybe people are busy today, today being Thursday. We may check with everyone if, Thursday is not a good day for the class, then we can change the day accordingly. But anyhow, for everyone who are here today, welcome. Gilles could not be with us today. He had a family emergency. So I will be taking the entire session today. Since we are small in number, I would try to wrap it up quickly, and we'll try to engage more into discussions today so that we can hear from everyone who's here today. Okay. So this week's classroom session is focused on governance and stakeholders, in supply chain. As you are studying in the first couple of modules 1 and 2, we're talking a lot about, how supply chains are governed, what kind of stakeholders are there in supply chain, who manages, who governs, who is the central authority for a national supply chain. So this is what we are going to be discussing today in more details. Now, this particular session, this is a topic which will help you, think more about your national supply chains. So that you can do a critical thinking of how different stakeholders interact with each other, and how supply chains should be governed so that they meet the objectives. So the objective of any supply chain would be, if we talk about pharmaceutical supply chains, their objectives would be to make sure that the pharmaceutical products are made available to the patients or consumer at the right price in the most affordable manner, and whenever they are required. So the products are there when someone falls sick, right, and at the right place, so at the health centers, and at the right quality as well. So that is the objective of any supply chain. So how all these stakeholders interact to make sure that the supply chains, they achieve their objective. So before moving on to this particular session, I'm going back to one of the discussions that has been posted in module 1, which is how do you contribute to health system. Now, I've been reading a lot of responses from all of you. The reason why we have this discussion is for you to think beyond your day-to-day jobs, and to understand how you as one health worker or a health workforce, someone in health workforce, how do you contribute to a large health system? As you studied in module 1, where we discussed what a health system is, what are different components or building blocks of a health system is. So we would want to know from you how, as someone in a health workforce, how do you contribute to a health system, or a national health system, or someone may be contributing to a global health system. So the floor is open now. So if anyone would like to speak and let us know how they think they contribute to a health system, that would be great. Yes, Wilson, please go ahead.
Thank you. Good day to everyone. Hello,
Yeah,
can you
all hear you? Yes, we can hear you.
Right. The question is, how do you contribute to health systems? I want to specifically talk about the supply chain. I believe the area that I would want to focus, especially this part of Africa that we have been in, I've been analyzing the Global Fund reports for sub-Saharan Africa, and the majority of them, they said the supply chains were not effective, and the problem had to do with adhering to good distribution practices. So as the in-country logistics, as well as the upstream logistics, I believe I would want to play a part in enforcing and strengthening the adherence to good distribution practices guidelines, which in then will ensure that as the patients receives the medicines, their quality, safety, and efficacy is not compromised. And these standards are universal because they were promulgated by the World Health Organization. So in a nutshell, I would like to say, I would want to contribute by capacity building of fellow health providers in Africa in adherence to WHO good distribution practices guidelines, which are essential in ensuring that medicines, they reach the intended beneficiary whilst the quality, safety, and efficacy is preserved. Thank you, Sanjay, and the team.
Thank you so much, Wilson. That's a great way of putting it. Yes, of course, if you ensure that products, they maintain their integrity and their quality during the transportation, and then that would mean that the patients are getting the high quality products, and the prescribers and the physicians who are doing their job at the health center level, it is also convenient for them to prescribe those products. So that's a great way to put your contribution to health system. Excellent. Anyone else would like to talk about how they contribute to health system, or how they would like to contribute to health system in future? Yes, Abdul, please go ahead.
Yeah, hello, Sanjay. Is my first time to be part of a organization that is the word is the word is not coming in my head. That is working in a health system. For the experience that I have, one day I went to in a hospital, and to get a medicine, I've spent more than 2 or 3 hours before I've been served to that medicine. It doesn't make me feel right, and I was asking myself, how could I do something to change this situation? If I were in the place of the person that could provide that medicine to that hospital, what can I do? And today I'm in an organization that is working in a health system, but we are not providing directly the products to the hospital or to the patient. We are just helping the government to fulfill his goal, that is to make everybody have access to a good health system. So today, I'm just asking myself, with this course that I'm taking, what will be my contribution? What can I learn and implement to let my company implement something good to help the government contribute to a good health system in my country? So I'm looking forward to learn a lot about you about the colleague, about the participants, so that I could be able to gain something after this course.
Excellent. Thank you so much, Abdul. And I'm sure as you grow professionally in your career, you would see that eventually whatever you do in a health sector, it somehow has the linkage where your good work is contributing to the betterment of the health system. Excellent. So with this, let me quickly move on with today's session. We have one more participant. Welcome, Judy. Today we are not seeing so many participants. Probably they are busy, so it's good that you have joined us. So the objective of today's session, like I said earlier, is to recognize how public health supply chains are governed at the country level. What are the different complexities, and how different products they flow between different supply chain tiers or supply chain network. We will discuss these concepts, and there are some questions that again we will like to discuss amongst all of you. Which this session is more of a critical thinking and a discussion session. Here, we're not talking so much about skills, but we're trying to help you understand or gain some critical insights about your own or your country's own supply chain. Okay, in case you want to speak, you can raise your hand. You can also put down your thoughts in the chat if you right. And wherever there will be some discussion, so we will open the floor for everyone, and there will be some polls as well, like the previous session. So beginning this session with a concept which probably most of you are aware of, but how it affects our supply chains, our health systems, that is something to understand here. So any health system or any supply chain system, it depends on how these health systems have been organized in your country from an administrative point of view as well. There are some countries where there is a centralized system. It's a centralized system of government as well, in general in those countries. While there are some countries where the governance is decentralized. Nigeria is one example where there is a federal government at a national level, and then every state, they have their own governments, and who manages their own administrative areas, for example, health. Similarly, there can be some smaller countries where it is a centralized structure, where there is only one organization or there is only one government which is working with different provinces or different districts. And similarly, the health is also managed centrally. So supply chains also function according to these administrative structures. There are certain countries where there's a centralized system. There is one central warehousing or and procurement authority. They procure everything. They warehouse everything which comes from probably outside the country or manufactured locally, and then they distribute directly to the hospitals, health centers, based on the demands. There can be another system where it's totally decentralized, where there's also a central body, but every state has their own warehouses, their own procurement system or distribution systems, and then they distribute it to the health centers or hospitals. And then there are some countries who are kind of in the middle. They also have central structure, they also have decentralized structure, so it's kind of in the mix. Okay, so again, it is important to understand these structures, because based on this, the supply chain can be it can be very complex, or it can be relatively easier to understand. So for example, in a centralized system, you would find less number of warehouses. You would find the central warehouse doing most of the work, and the health centers, hospitals, they are requesting the products directly from the central warehouse. In bigger countries, you would find a lot of warehouses. There may be more than one central warehouse depending on the locations. There can be state warehouse, provincial warehouse, district warehouse, and products may flow from one place to the other until it reaches the hospitals or the health centers, right? And the demand allocation might also be different. Their financial management can also be centralized or decentralized. So based on this administrative structures, the governance of supply chain it changes, it varies from country to country because of these administrative structures, how the countries are, their governance is organized. So with this in mind, let me ask you, it's a quick poll here, that how is it that the health system is organized in your country, in your own country, whether it is centralized, it is decentralized, or it is a mixed, where you see both things happening. So the polls should be on your screen now. It would be good to understand where your country stands with this structure of health systems and supply chain. Oh, sorry, this is a wrong poll that I've by mistake shared. Let me okay. Sorry, I'm sorry, this, for some reason this poll is not coming on my screen. So then let me just ask you, if anyone wants to just unmute themselves and talk whether it's a centralized structure or a decentralized structure of health system in their country. Anyone can just unmute and talk about it. Negedu, Wilson, Abdul, Kolo, and if any of you can talk, you can also write your answer in the chat.
Yeah, so me, as you rightly mentioned,
it's Wilson.
Okay, sorry, go ahead, please.
Okay, no issue, Negedu, go on.
No, I said, as you mentioned earlier, I'm from Nigeria and our system is decentralized. And even the decentralized system, although the Federal Ministry of Health still have some control over some certain kind of commodities, but in terms of real administration and the procurement of health commodities is done by the states, which may be region in some countries, or what is done by the states in Nigeria. Okay. Thank you.
Okay, excellent. Wilson?
Hello, yes, in Zimbabwe, our healthcare supply system is centralized. It is managed by a government-owned company called National Pharmaceutical Company, in short, NatFarm. So NatFarm has got a central warehouse, and then within certain provinces, it has got a regional warehouses. So, for example, medical commodities, they move from the central warehouse into the regional warehouse, which then distributes to health centers. It is centralized in Zimbabwe. Thank you.
Okay. Bethel, can we hear from you? Okay, maybe she doesn't want to speak. Okay, anyways, so we got both sides of the spectrum. So one is centralized, one is decentralized. For example, if I talk about India, where I am right now, so in India, it's kind of mixed. It depends on the commodity. Okay, Bethel, you are unmuted.
Yes, sorry.
Okay, you
Can
want
you hear
to
me
talk
now?
about, yes, we can hear you.
Okay.
So do you want to answer this question? How is the health system organized in Ethiopia?
Okay, sure. In Ethiopia, the health system is more of centralized. It's managed by the government, the Ministry of Health, and also there's a huge procurement system, which is pharmaceutical and medical supplies are procured through a central system in a government. It's called Pharmaceutical Supply Agency. So there are a lot of private health sectors, but they are supporting the government. They are not considered as the main or health system. So they are like supporting the government. But mainly in Ethiopia, the health system is managed by the government. So it's centralized.
Centralized. Okay, excellent, excellent. Okay, so like I was saying, so for example, if I talk about India, it's a mixed structure. It's very much like Nigeria, where the states are responsible for the procurement, distribution, and also the administration of health services, for example, in their own states. But then there are certain programs, there are certain health services, there are certain cadres which the federal government is responsible for, and they manage everything, and the states don't have any jurisdiction about that. So it's a mixed structure in India. There are other countries even in Africa where you have mixed structures. I believe, although Bethel is saying it's a centralized system in Ethiopia, from my own experience, I would say Ethiopia is kind of mixed, predominantly centralized, yes, but I believe in different regions, with the regional health bureaus and some other government organizations, they also make their own decisions for the regions, although they are guided by the federal government, the Ministry of Health. But I think they have some level of autonomy as well, to make some level of decision making at their own regions. They can also procure independently as well. I don't think it's mandatory for different regions to always procure from the Ethiopian Procurement and Supplies Agency. They can also procure from private sector. So it's a mixed, I would say, in Ethiopia. Similarly, if I talk about Kenya, it's predominantly centralized, but then different counties, they have their own administrative structures as well. For a long time, Kenya was centralized. But after the devolution in Kenya, I would say it's predominantly centralized, but then a lot of health system decisions are taken by the counties themselves. So it's again a mixed structure. So if we move ahead, then why are we talking about this central and decentralized systems? It is because the accountability for the health system, the accountability for supply chains, the responsibilities for health system and supply chains, they would then vary according to the administrative structure. And as you would understand, the organization who is it is very critical to understand in a very clear term who are the organizations who are accountable and responsible to manage the supply chains in the country. Now, for example, if I take an example of Ethiopia, the accountable organization would be Federal Ministry of Health. They are accountable for ensuring the health of the citizens of Ethiopia. But the responsible authority who is managing the supply chain in Ethiopia is Ethiopian Pharmaceutical Supply Agency, or now they're calling themselves EPSS, Ethiopian Pharmaceutical Supply Services, for example. So they are the organization who is responsible to manage the supply chain in health in Ethiopia, for example. Similarly, in Nigeria, the accountabilities are quite diffused, although it also lies with the Federal Ministry of Health at a federal level, but all the states, their own state Ministry of Health are also equally accountable for the supply chain and the health of for the supply chain of pharmaceutical products in their own states. And the responsibilities, they may lie with the LMCUs, they may lie with the drug management agency. So these accountabilities and responsibilities would vary depending on who is the organization and how those accountabilities are administratively managed in that particular country or state. And as you see on this slide, we talk about how these organizations then influence the supply chain processes. So the supply chain processes like quantification, procurement, warehousing, distribution, quality assurance, information management. So all those things will be then influenced by that particular organization or group of stakeholders. Similarly, organizational processes. Organizational processes like finance, administration, human resource management. So those are some organizational processes that will also be influenced by these organizations who are accountable or responsible for the supply chain. And of course, the stakeholders. So whoever is the central stakeholder for supply chain, central organization for supply chain, it will be their job to manage other stakeholders who are involved in the supply chain of the country. So that's why we are talking about why it is important to understand whether it is a centralized structure or a decentralized structure. Why? Because the accountabilities and the responsibilities will vary depending on how the structure of health system in the country is. And hence, the influence on supply chain process, organizational processes, and stakeholders will vary. Okay. Anytime if you have any questions, you can please raise your hands. Okay. So this brings me to the first group discussion. This is about stakeholders in a country. Okay. As we all know, that in the countries that we are in, although our supply chains are managed by the government, and through government, there are some parastatal organizations or some other organizations who are working under the government to manage the supply chain. But there are a lot of donors, external donors, who are active in the countries, and they may have their own degree of influence on that country's supply chain because they invest heavily in any country's supply chain. So the question here is for everyone is that, do you know which donors are active in your country and what kind of influence that they have over your country's health supply chain? So the floor is open for everyone. It would be good to understand how donors interact with your country's health supply chain. Okay, so I would request anyone who would like to begin. Maybe we'd like to hear from Judy, who has joined recently, or anyone else who would like to speak. You're all welcome.
Yeah, thank you very much. Just off the top of my head, I know of UNICEF, Gavi, that influences the vaccine supply chain in Kenya, and also UNFPA influences the family planning supply chain also in Kenya. So the influence is in terms of the stocks that come in and how often they get replenished.
Mm. Excellent, Judy. That's a great answer. You also talked about how they're influencing the supply chain. That's great. Anyone else?
Hi, Sanjay. Sanjay, this is Kolo.
Yes, Kolo.
Yes, I know for Nigeria, the biggest players are Global Fund and USAID. Global Fund is responsible largely for commodities to do with AIDS, tuberculosis, and malaria. They are, the big players there. So they buy the mosquito net, the prepackaged anti-malaria therapy, HIV drugs, and pass them through the central system through the states, like program-funded commodities. USAID, on the other hand, supports the strengthening and heavy lifting, supply, procurement, forecasting for most of the essential drugs go through the health system, specifically could be drugs associated with maternal and child health. They are also into family planning, reproductive health commodities like that. So there are the two big players here in Nigeria. There are lots of other donors who are also supporting here and there, like we did here, UNFPA also, some organizations also do fund commodities, like Maristopes is also into Maristopes fund, family planning commodities and all that. But generally, the two big players are those that influence the country's supply chain, especially the biggest one is Global Fund in countries. Yeah.
Okay, excellent. Abdul, you had raised your hand. Do you want to go now? Yes, Abdul. Okay, Bethel, you have raised your hand. Bethel, you can speak now. Yes, Bethel, you can speak now.
So in case of Ethiopia, I know a number of donors who are influencing the health supply chain system. I can mention Global Fund for HIV/AIDS, ARV medicines and medical supplies for HIV, and also malaria. I know Chemonix International has also a malaria and some other products that are procured under Chemonix International.
But
And
would you consider Chemonix as a donor or a technical agency?
it's more of a technical agency, but it has a little bit of a procurement that supports the government.
Yeah,
like
but the funds are
laboratory
coming
rate.
from USAID, no?
Yes, you said, sure.
Yes. So donor is USAID and the managing organization is Chemonix, right?
Chemonix, that's right.
Okay. Yes.
And also for some vaccines, I know UNICEF through
Gavi.
Gavi, thank you very much, through Gavi. So the vaccines and vaccine supplies are supported through UNICEF.
Okay, excellent.
So the mainly these essential drugs are covered by the government, and many more program drugs are supported by donors.
Okay, Wilson, you have raised your hand. You can go next.
Thank you. Hi to everyone. In Zimbabwe, what happens is after the quantification and supply planning has been done, and then consideration has been made in terms of the shortfalls. So the donors, they then come in. The major donor is the Health Development Fund, which is managed through UNICEF. And it is responsible for maternal health and childcare. They influence the supply chain in a bigger way. One, they are involved in bringing in the health commodities, your first line medicaments. So the trust with UNICEF is low cost but high impact. For example, they will rather procure amoxicillin, pediatric cotrimoxazole to cure small problems at primary level, such that the secondary and tertiary level of healthcare is not overwhelmed. So they're involved in procuring. They are also involved in taking the assistant of NatFarm, the central warehouse. They then go further. UNICEF, every quarter, they actually send data enumerators to every health facility in Zimbabwe to check for availability of vital medicines and healthcare services. Let's say, for example, was benzodiazepine penicillin supplied? Were family planning tablets supplied? How many beds were available? So UNICEF is the major donor. Then we've got the Global Fund. The Global Fund is managed through UNDP, is the principal recipient. Then the government of Zimbabwe also is the also principal recipient, but for TB and HIV. Then the Central Medical also is a sub-recipient of the Global Fund. So Global Fund is also a major player. So what then they did is they then nominated an upstream logistics coordinator who is based at the Central Medical Stores, who is responsible for coordinating all the donors such that there's no duplication of medicines that are delivered, and he scheduled delivery of that medicine such that there is no pressure at the health center. But in a nutshell, Zimbabwe, we heavily rely on donors, and the major donors being UNICEF, Global Fund, Health Development Fund, and as well as USAID. There is also Crown Agency. They manage what is called resource-based financing, where there's been flight of skilled healthcare workers. So through Crown agents, they also pay for those. So Crown agents is also involved in so far as funding the supply chain healthcare workers within the system, the team.
But again, Wilson, would you consider Crown agents as a technical management organization being funded by the UK British government, or would you consider Crown agents as donors themselves?
Crown agents, I think they are a technical agent funded by the UK, but in Zimbabwe, they also work with other NGOs because of their skills. For example, the UNICEF survey is actually administered through Crown agency because they've got expertise on the ground.
Okay, excellent, excellent. Anyone else want to speak now? I guess Bethel wanted to speak or not. I don't know. Bethel has already spoken. Yes.
Yes, I did.
Okay. Abdul, anything from your side? Yes. Abdul, go on.
Yes, I think as well as Zimbabwe, in Benin, the major donor in health system is UNICEF. And a part of UNICEF, we have UNFPA and Plan International, who really play a key role in our health system coverage. So today, most of our villages and sub-areas are provided in medicine and essential medication by UNICEF and those donors. So they are just helping the government to reach all those people that are in the need of medicine and health system today. So I think that's the biggest donors we have actually. But we even have some little donors, such as, I'll call them little donors because they are not really in the health department, but they try to import their help to contribute. If I can name like, how we call them, CRS, Catholic Relief Services, CRS to give some help in that way, but it's not a bigger donor as UNICEF or UNFPA and Plan International.
So CRS is for faith-based institutions, I guess. So that's that goes towards a different set of supply chains and clinical services, because I believe, I think they're also in other countries like Nigeria. I think they're also in Kenya. So CRS is a big organization, but their operations in different countries may depend on the Catholic group and the Catholics health system, the way it is organized in that country. So yes, one key point over here in this question is, how do donors influence the supply chain in your country? So for example, how Judith had mentioned in the beginning, how I don't know I just forgot which donor that she was talking about. I guess it was UNICEF probably. I know UNICEF has been talked about by other people as well. But the donors, there are several donors, like Global Fund or USAID, who would have their own guidelines for the national supply chains to follow. So for example, if you are being funded by Global Fund for HIV, TB, malaria, and now for COVID, you can only purchase from a certain set of suppliers, right? UNICEF may do the procurement themselves and only want you to want the national supply chain to store and distribute the commodities. They may not want to give the national supply chain the procuring authority. Similarly, just like someone said right now, like Wilson said, that some organizations like UNFPA or UNICEF, they would send their own data collection system. They would have their own data collection systems to be sent to health facilities to understand the consumption of products, to understand the extent of health services. So that's also another way how they're influencing the supply chain, although they are able to get the data out of the health centers, but the same health centers are not sending the data for essential medicines, which the national government or the national supply chain systems are managing. So it creates a bit of a disparity sometimes. I mean, back, if we go a few years back, if we go about 5-10 years back, most of the countries, they had parallel supply chains as well. Although right now, if we talk about Ethiopia, if we talk about Kenya, the number of parallel supply chains, they're probably very few, or at the mostly integrated. In Nigeria, there may be a few parallel supply chains still existing today. I'm not so sure about Benin. But back in the day, there were a lot of parallel supply chains because of the influence by the donors. Now, in the last 5 to 10 years, most countries have invested in central warehousing, central procuring authorities, and all the donors have been asked to consolidate their efforts through that agency. And that's how different parallel supply chains have become one horizontal supply chain as well. So it is very important to understand their circle of influence, because if you are working with the national supply chain organization, and for example, sometimes you're working for a specific product, you may have certain guidelines to follow. If you are working with a donor organization, or for example, if someone is working, so I think Bethel is working for UNICEF, Methendrik, who's not here today, he works for USAID. You will be responsible for creating those guidelines and coordinating with the national counterparts to make sure that the products that you are responsible for, they are managed properly. But as donors, as technical organizations, your role should not just end there. Ideally, the role of these donors, role of UN organizations should be to develop the system, so that the system can manage all kind of products, because we have seen several places that the systems for HIV products, TB products, vaccines are working so well, but at the same time, they're not working so well for other commodities like other essential medicines, which you need on a daily basis. For example, medicines for diabetes, medicines for hypertension, antibacterials. So those things are not working so well. Okay, so the role for donors is to make sure that the system is being strengthened, and not just that the products that they are focusing on should do better. So with this in mind, let's move ahead to a very quick poll. This poll, this is very interesting all the time. If this is a small group, the results may not be that representative, but let me still go ahead and launch this poll. I'll tell you why. Relaunch. Once the poll is launched, I'll tell you why. Yeah. Okay. So the reason why we ask this question a lot of times, that why, if you consider pharmaceutical manufacturers as part of a supply chains, is because there are several countries where governments they don't coordinate with suppliers as effectively as they should. Now, this is a mindset that should be changed. In some countries, they do. They are doing very well, but there are countries, and one of the countries that Bethel is representing, Ethiopia. I've personally worked a lot in Ethiopia. In Ethiopia, majority of the products are imported from outside. But given the administrative structures of Ethiopia, it becomes very difficult for international suppliers to coordinate with national counterparts. Now it has been started in the last couple of years, but it has been very difficult in the past for suppliers to coordinate with the national organizations. There have been instances where the suppliers have not been paid for a very long time. There have been instances where the suppliers have refused to take part in national tenders or international tenders because they know of the issues that they're going to face in Ethiopia. So if when we say that we feel that suppliers are part of the supply chain, that means that for major supply chain decisions, whoever the authority that is responsible for supply chain should also coordinate with, or at least get some information from the suppliers when they're taking big supply chain decisions. So that is the meaning when we say that whether suppliers are considered as part of supply chain or not. Okay. Not many people have responded to this. We still have a few more people who can respond to this question. But while this is still on, we can go ahead to the next. Next is Q&A. So if there are any questions that you have so far, although we have not covered a lot so far in the session, but in case there are any questions, you can raise your hand or you can also write in chat and we can take that question. So most people, they believe they are part of health supply chain. But one thing is that, yes, we do believe that they're intrinsic part of health supply chain in the countries. But it is important to also note that if they are part of supply chains, then the manufacturer should be also involved in some form, at least to gather information when major decisions are being taken, right? It can be regarding while launching new treatments. It can be regarding how a product should be stored or it should be distributed, or designing product packaging. So those kind of things, manufacturers can be, brought in, the workshops can be done, surveys can be done, and their point of views can also be understood while designing, while taking supply chain decisions. Wilson, yes, you have raised your hand. Is there any question?
No, my comment was on the manufacturers, especially the local manufacturers. Like in terms of us in Zimbabwe, they are a part of the supply chain, but the challenge is for major programs like the Global Fund, UNICEF, because they have got a pre-qualification. That pre-qualification is quite stringent. So most of the local manufacturers might not meet those requirements. So at the end of the day, they lose out. So what has been happening is, in terms of now the local tenders that are funded by the government, they are now exclusively being given to the local manufacturers. But sometimes also the local manufacturers themselves, they also fail to meet the demand. Yes, they've been given an order, but the turnaround time is also difficult. So at the end of the day, local manufacturers, they are quite facing a bit of challenges. They cannot compete with international manufacturers. Another example is our Medicine Control Authority of Zimbabwe. 90% of products that are registered, they are imports. And of those 90%, 75% are international products. So that's the challenge with the local manufacturers. They don't have the capacity to compete with international players.
Yeah. And that's the situation in almost every second country in Africa. I believe, except South Africa, to some extent now in Kenya, and I don't know about Nigeria. Nigeria may have a good amount of local manufacturing, but still, I believe at least 60 to 70% of products are still being imported into Nigeria as well from, globally, from India, from Europe, from US. That's a common challenge everywhere, and I think that is where the governments needs to create associations or with associations with manufacturers, with manufacturer forums, where they can strengthen their capacity so that local manufacturers can also support the public health system. Otherwise, what happens is these local manufacturers, they're always involved in the private sector. They may not always have the best quality systems at hand, and hence the quality of products will suffer, and eventually who will suffer is the patient. But it's the again responsibility of the government to bring capacity to these manufacturers and suppliers, and that's why it's important to understand the role that these manufacturers play in any country's health system. So moving on very quickly. So now that we've understood the administrative structures and how different stakeholders, they influence national supply chains, it is important to understand that the supply chain operations of any country depend on how that public sector organization is governed. Now, when I say governance, it has its roots in organizational management. So what I'm trying to say is how that organization is managed. Again, the first thing under governance is whether it is centralized or decentralized, which we've discussed earlier. How are the legal structures designed between that central medical store, or for example, in Ethiopia, it is IPSA. In Zimbabwe's case, it is NatFarm. How are those legal structures between that organization, the Ministry of Health, or the government of the country, or the different states that they are working in? What are the policies on human resource management, on financial management, public procurement? Those policies and those guidelines, they also come under governance, because without these policies, without these structures, a supply chain organization cannot function. Then, like we discussed, presence of the donor ecosystem, because a big portion of health supply chains in the countries that we're discussing is being financed by the donors. So what is the donor ecosystem in that country? And then, of course, the other thing that we discussed are the private commercial sector, such as pharmaceutical manufacturers, logistic service providers, wholesalers, distributors. So all these things, how interact with each other, how they're managed by the government or that responsible authority is important, and that is what we consider under governance. So the supply chain operation of any country will highly depend on all these structures or all these associations that we talk under governance. So for example, if we talk about human resource management, human resource management would mean how health workforce is being readied for the sector. So for example, what kind of education is there for pharmacies, for pharmacists, for doctors, for nurses, how they are brought into the workforce, what kind of job opportunities are there in the supply chain organization, how they are recruiting, whether that supply chain organization they can recruit by themselves or they are dependent on another organization. For example, in Ethiopia, the supply chain organization, which is EPSS, like we discussed earlier, they cannot recruit directly. They are dependent upon another organization called the Public Service Commission. So because EPSS is a government organization, so they are dependent on Public Service Commission for recruitment. And they also cannot fire anyone. They also cannot let go of their staff. It is also dependent on Public Service Commission. So there is a constraint where EPSS, they don't know who is going to be recruited for their job functions. And if someone is not performing well, they cannot directly let them go. They have to go through different channels, and those channels are sometimes so long that they don't let go of people. Okay. Similarly, if we talk about Uganda, their supply chain organization, which is National Medical Stores, they have full control over their human resource management. So they hire directly. They advertise their own positions. They hire directly, and they can also fire people based on non-performance. So it's very important to understand how these systems and processes are managed within the health supply chains, because on one side we think that supply chain is only about, okay, this is the product that is required, this is the amount of product based on forecasting, quantification, okay, let's procure it from somewhere, whether it is internationally or from local manufacturers, then let's us warehouse it and send it to the health centers. But to do that, we need people, and the people need to be recruited with the right capability, with the right skills, from the right institutions, at the right salary scale. They need to be paid, and to pay them, there has to be some financial structure. Those people need to work at a certain place. They would need some office. They would need some infrastructure. So all these things are very important, and all of it comes under governance. So it is very important to understand governance of your own organizations. So for example, if Bethel is working in UNICEF, how is UNICEF governed? If Wilson is working in a health center, how it is managed? If he is coordinating with NatFarm, how is NatFarm being governed? If Abdul, I forgot Abdul where you're working, but how is that organization governed? Because that governance will influence how your organization is managing the supply chain, or how your organization is supporting supply chain of the country. Okay. So if we quickly move ahead, so the question for you is, does the supply chain organization in your country have full authority on finance, procurement, and human resource management? So just like I was talking about, giving an example of Ethiopia. So let us hear from everyone to understand whether you know, or maybe you may not know, but whoever knows, please do let us know if the supply chain organization, now I'm very specifically talking about the supply chain organization. So in Ethiopia, it is IPSA. In Zimbabwe, it is NatFarm. In Benin, Abdul will have to let us know. In Kenya, it is KEMSA. In Nigeria, there are various. So, but for any particular state, we can take an example of the state for Nigeria. But do they have full authority on these functions? So over to you. And pardon me, I'm still not fully recovered from COVID. There is still a bit of residual infection.
Hello, Sanjay.
Yes, Wilson.
Right. For NatFarm, yeah, in terms of public finance, the authority, all of the budgetary control obviously rests with the Ministry of Finance. So they are only allocated what the Ministry of Finance allocates during the national budget. So I wouldn't say they've got full control, it's partial control. Then in terms of procurement also, it's also governed by the Procurement Regulatory Authority of Zimbabwe. They have to work or have certain exemptions from the Procurement Regulatory Authority. So I would also say it's partial authority. In terms of then human resources management, yes, these they have got a full authority for management. But in terms of the board, they are also appointed by the minister, by the Minister of Health. So in of the three parameters, I will say they've got partial control. Especially procurement is a challenge, and there's been a challenge. I think if you read the news or on the internet, NatFarm has had a lot of challenges, especially to do with procurement of COVID. There have been a lot of challenges. Thank you very much.
Thank you, Wilson. Okay, Judith is saying in Kenya, she doesn't think KEMSA have full authority across all the domains. Yeah, I guess I believe so. At least for finance, they may not have full authority, but I think for procurement, at least for essential medicines, I think they have. But now, of course, in Kenya, there are other issues that KEMSA is managing, like there is a big, court case, legal issue of corruption that has come about, and I think a lot of donor agencies have written to the government to stop KEMSA in doing some sort of procurement for some commodities as well. So that's a different issue altogether. Okay, Abdul is saying in Benin. So first of all, Abdul, just a quick question: who is the central authority for supply chain in Benin, or is it there are more than one stakeholder in Benin? If you can just enlighten us, please. Yes, Abdul.
Senji, I didn't get the question. Can you repeat, please?
So I'm saying, if you can let us know who is the main organization who is responsible for supply chain in Benin, health supply chain in Benin. If you can let us know.
In Benin is CAME. We call it Central of Purchase of Essential Medicine. And even UNICEF and the other organization put the stock of products in that central, and is that central that is responsible of distributing the medicine in other areas. So it's centralized. Yes, it's centralized.
Okay. But you think they don't have full authority on finance or procurement or human resource?
No, I don't think, because even them, they are under another authority. So they are under the authority of the National Health Ministry. So sometimes they don't have the full authority on what they are doing.
So CAME would be then parastatal, I would say. You understand parastatal organization? I don't know how to call it in French. Maybe Andrea can help.
Andrea can help.
Andrea, how do you call parastatal in French?
I believe me, I don't know. I need to.
Oh, that's a very technical term. Anyways, so generally parastatal is an organization, Abdul, which is affiliated to the government, which is not fully independent. They have to take some decisions, based on discussions with the government. Yes, it's half government, half private, but sometimes it can be more than half as well. It depends on how different countries in different places, how they define parastatal, But anyway, so I think that's how CAME is functioning. So yes, so it's a good debate here that in some countries, they may have full authority, but I think here in most countries that you're representing, most organizations, they don't have the full authority on finance, procurement, human resource management. At least parapublic, yes, I think that's how they mention in French. Yeah. At least for finance, most organizations, they may not have full authority. They may still be dependent on Ministry of Health or Ministry of Finance. But I think for procurement and human resource, they can have a lot of authority. Yeah. So moving on, if there are any questions, please, you can raise your hands anytime. But I will quickly move on to this next section, which is quite important. And it also, there is a assignment as well for all of you at the end of module 2. So it is important to discuss this in detail. Now, eventually, when we have talked about how supply chain is governed in your countries, who the stakeholders are, what are the different complexities. The reason why we have studied all that before so that now we can fully understand how the products flow in your countries, how the funds flow in your country's supply chain, and how does the information flow in your country's supply chain. It is important to understand the governance and the stakeholders and administrative structures before this, so that now it will make more sense to you. So for example, the flow of products, it depends on your administrative structures, whether it is a centralized structure or a decentralized structures, what kind of stakeholders are in your country, whether the warehousing is only managed by one organization or it is managed by several organizations. For example, in Bangladesh, just a quick example, supply chain, the national supply chain is managed by 3 or 4 different organizations. It is managed by Ministry of Health. It is also managed by several NGOs. For example, there is one called BRAC. Now, these NGOs, they also have their own warehouses. So there is no central point. So the products, when they come into the country, depending on product categories, they will go to the designated warehouses. But eventually, from all the warehouses, the products will go to the same health center, because the health centers are not divided. They're the same health center for all health services. So from every warehouse, the product will then move in their own designated vehicles to go to that particular warehouse. So that's how, depending on how the supply chain structure is, how the administrative structures are, the flow of products may differ. The important thing when we talk about flow of products is to understand the number of points the product is stored at, because that contributes to cost, that has a relationship with the product quality, and that has also a relationship with time. So how quickly the product can reach the end point where it will be dispensed, right? So if there is only one point of main storage, which is the central warehouse, and the health centers or hospitals are directly sending their requisition to the central warehouse, then the products will reach the health centers faster, depending on, of course, the processes in that particular country. But if there are different set of warehouses, like a central warehouse, then a regional warehouse, then a district warehouse, so there are different turns. The regional warehouse will request from the central warehouse. The district warehouse or the provincial warehouse will send a request to the regional warehouse. Then the hospital will send a request to the district warehouse or the provincial warehouse. So there are different turns. So it will take more time for the product to reach the beneficiary or the health center. It will be more expensive. There will be more instances of issues in quality, because maybe it was kept very well at the central warehouse level, but then at a regional warehouse they did not store it properly, or while transportation there were some issues. So as long as the product spends in transportation or in different places of storage, there are more chances of quality deterioration. Then, as you see on this slide, this one talks about the same thing that I'm talking about, that there is no central organization. So for example, if we take an example of let's say if we take an example of Nigeria, right? So different states, they have their own central warehouses. So one big manufacturer, let's say, for example, take an example of Pfizer. Pfizer is a very big manufacturer, a big supplier of products in Nigeria, for example. So Pfizer is supplying to 20 states, or, I'm just giving a hypothetical situation. So Pfizer is supplying to 20 states the same product, but every time a state needs a product, they will do a separate procurement with Pfizer and they will send it to their warehouse. Now, we don't know exactly if there is a single point where Pfizer is storing those products in country, but every time they're coming into the country and going to separate states, right? So every state has their own warehouse. The supplier is sending differently to different states' warehouses. Then those states, from their own state central warehouse, they are going to different places for storage, eventually reaching the health center or the hospital where those products are being dispensed. So that is creating more complexity for the supplier. It is creating more complexity for the system itself because of several points of storage and different ways of transporting that product from one place to the other. And similarly, like I gave the example of Bangladesh. So this, what you see on the slide is also prevalent in Bangladesh. So, you know, the product is going to different warehouses, and from there it is reaching the same health center, but through various supply chains, because they are being managed by different organizations and in their own warehouses, and who are transporting those products using their own vehicles. So there is no harmonization, there is no horizontal system, but there are more vertical systems. So in this case, again, like I said, it is very important to understand that as many places that the product will go, there will be impact on finance, there will be impact on quality, there will also be an impact on information. You know, where, what is the source of information, who's collecting the information, and from where. So those things need to be understood while designing a supply chain. You know, so these are the things that once you see your current supply chain, you can understand, okay, whether there is a level where the product is stored is actually redundant. If that level, even if it is not there, will not really affect the supply chain in your country. But you will only know that once you know how your supply chain is designed. Wilson, yes, you have raised your hand.
Hi, Sanjay. I have observed a lot of times, even a lot of literature, in terms of the supply chain for health. Like in Africa, we agree that 60 to 70% of the products are imported. So when we are designing the supply chain, it only starts from the supplier already. We are going to the warehouse. I felt that maybe we need to consider the upstream logistics, like your international procurement and the shipping, port clearances, and so forth, because that area is a very high risk area. One, introduction of counterfeits, delays at the port, there are a lot of risks, temperature excursions, a lot of things. So I felt that maybe the new programs or the new courses, not only for BIF, but the general board of knowledge in terms of supply chain for health, we also need to focus in that area, especially which is the best mode of transport to use. Do you use sea freight? Do you use rail freight? Do you use rail? Do you use air? And so forth. But we are only focusing from the supplier to the central warehouse. Yet that international shipping is an area for concern. I'll give an example. Right now, UNICEF Zimbabwe is got the Bolore service provider because of the disturbances. He has got a big bearing in terms of the landed pricing, in terms of availability of the product. Thank you.
Yes, thank you, Wilson, for also raising that point, although we will cover it in a different lesson when we talk a lot about you know, how that transportation is structured in your contracts as well. It is really very important, you know, how the first mode of transportation is coming from the supplier to the central warehouse or whatever level that is, because most of the times it is coming from outside of the country. So either it is coming via ship, then it is you know, taken out at the port, and from the port of leading, it is then put into a truck, and the truck then reaches the central warehouse. So it is important to understand how well that transportation has happened when it was in a ship, and how that transportation has happened when it was laid on the truck. So those things we'll discuss more in another chapter when we talk more about procurement, how those clauses are put in, what are the Incoterms, who is responsible for that transportation, who bears the risk, what kind of insurances are you talking about. So those things we'll discuss at a later stage. Right now, what we're focused on more is how the structure of the supply chain is in your own country, and who are the stakeholders who are involved. Okay. So the second thing that from products that we come to is money. It is finance. That the key question is who pays for these products, and how does then that money flow from one place to the other. So typically, if in any country, if you look at it, there are mostly these three sources. One, the patient is paying for the product. Second, the government is paying for the products. And third, the donors are paying for the product. If you look at the public health system in your countries, you will find that for the program products, it is the donors that they are paying predominantly. So the national government is not really paying for what you call the program products, or some may call essential products like HIV, TB, malaria, family planning, right now for COVID as well. And then there can be some other smaller programs as well, like what do you call the tropical diseases, neglected tropical diseases. So those kind of programs are being paid for by the donors. Then there is a mix. In some countries, it's the government who's paying for essential medicines. Anything which is not a program product is directly paid for by the government. The government allocates that budget in their annual budget cycles from the taxes that they collect. And based on the budget that the government is allocating, the National Supply Chain Organization, they will procure those products, essential medicines, and they will distribute it to the health facilities where they are dispensed for free. So the patient is not paying over there. The patient may pay for the health service, but they're not paying for the product. So for example, in India, this is the model. So for majority of essential products in the public health system, the patient only pays a user fee or a service fee. They don't pay for the product because it is already being paid by the government using the taxes which are collected from the citizens themselves. So the patient doesn't have to pay for the product itself. In the public institution, in the private institution, yes, they have to pay, but not in the public institution. In the third, which is the patient, in most African countries, products are not free. They might be subsidized. They may be less expensive than that the private sector, but they are not free for the patient. So the patient has to pay for the product as well. So the patient may be paying for the health service. So for example, they're paying for the doctor's fee. They are paying for the diagnosis. They're also paying for the product. And yes, like Bethel is mentioning in the chat, that it is done through something called a revolving drug fund or a drug revolving fund, which means that whatever the patient is paying for the drugs, that money is pulled from various places, and that same money is reused to procure those products which are being used in the public health system. So it's a revolving structure. So in the revolving drug fund, there is a primary pool when it starts, which is being given by the government or by a donor, using which the National Supply Chain Organization will procure the products. Then when they sell those products to the hospitals or the regions or the health centers, so those hospitals and health centers, they will pay this National Supply Chain Organization based on the service that, when they will give it to the patient. So eventually the patient is paying. That money is collected, accumulated at a central place, and that money is then reused to buy the products again, which is called a revolving drug fund. And it is being used in several countries. It is being used in Kenya, it is being used in Ethiopia, in Sudan, and then there are some other countries. But these three countries, why I'm mentioning is because they have fairly good systems of revolving drug fund. Okay. There is another way that the products can be financed. It can be through insurance as well. Although the reason why you don't see it on this slide is because in Africa, the prevalence of insurance is very low. There are very few countries where you would have some insurance. In Kenya, there is a national insurance fund, just like the UK. So probably in Kenya, to some extent, some products may be financed excuse me, through insurance, but majorly it is through a revolving drug fund. So the question then comes back to you. So who pays for the products in your country? You will see the poll on your screen right now. You can select more than one option in this case, because in some countries you can have more than one option as well. Again, this is important to understand from a supply chain perspective, is because supply chains can only function properly if they are adequately financed. So today, what we are learning is how supply chains run, the governance, the structure, the financing. So these are the things that we are learning today. From the next week, then we will go on to more core functions, from quantification, then to procurement, then to warehousing, then to transportation. So those are the things that we will discuss in the upcoming weeks. So it's a quite mix in the countries that are being represented here, but majorly in every country the patient pays. There are the essential medicines which are paid by the donors, and then in Kenya, and then in another country, I'm not sure which one, probably in Nigeria as well. There are some insurances, based on which some products can be financed as well. Okay. So that brings me to the third flow, which is information. Okay, yes, so Abdul, that's the same thing. Government provides some subsidies, but then eventually part of it still has to be paid by the patient. So yes, it's a mixed system. So coming back to the final flow, which is flow of information. Now again, in a supply chain, it is very important to understand the flow of information, because without that, it will be very difficult to make decisions in a supply chain. So decisions like how much do we need, how much to procure, when does a health center or a smaller warehouse need the product, when to do a resupply, when to contract a manufacturer, when to go for custom clearance. So all those information is required, and that's why the flow of information is very important. Okay. Like you see on the screen, there have been significant investments made for LMIS systems and eLMIS systems in most countries. A lot of countries you will find online systems. For example, in Kenya, you have an online system. In Ethiopia, it's mixed. To a certain point, they use something called HCMIS. But then at the health center, it is still manual. Or it is Excel based, and then the data is collected, and then decisions are made based on that. But in most countries, the end data, when I say end data, or let's say the consumption data or the demand, needs to be collected at the health center, health facility level, which is the key challenge in most countries. Because in most countries, the supply chain organization does not have any authority on the health centers, because the health centers are still managed by the Federal Ministry of Health or state level ministries of health. So if there is no control, they cannot force the health centers to submit their data. Yes, they do submit their data, but the quality may be poor, or they don't submit it at the right time. So there are so many instances when the decisions about demand forecasting or procurement are being taken using proxy data of supply. So for example, how much products are being supplied from the regional warehouse to the health center, the issue data, not the consumption data, because the consumption data would mean that how much product has been dispensed to the consumer or the patient. And if you make decisions based on that data, that gives you the actual understanding of the supply chain. So how the supply chain is functioning, what products are required at what quantity. But more often than not, this data becomes very difficult to collect because of the same thing that we learned earlier about who is responsible or who is accountable for that function. And in most cases, the health center and the hospitals, they are not under the supply chain organization. They're under a different entity, most often the Ministry of Health at a state level or at a national level. So then again, the key question comes back to you. How is that information management being done in your country? Is there an ELMIS, electronic LMIS, or a manual logistics management information system? And who manages it? And do you have any challenges or not? So anyone who wants to speak can just unmute themselves and speak. This is, I think, the last. Yes, this is the last question, after which we will end this session. Anyone? What about information, ELMIS? How is it managed? How does the information flow in your country's supply chain? Yes, Bethel, go on.
Okay, thank you, Sanjay. I'm not 100% sure, but in Ethiopia, as you have mentioned, there's the mixed system, like HMIs, which is some part of the health facilities use manually, and some part of the facilities, especially the hospitals and referral hospitals, use it electronically. But the responsible organization is Ministry of Health, and also for program, especially for program services like HIV/AIDS, or like there's an organization which is funded by USAID, that ICAP. ICAP also supports the government in its HMIs. So some part of the LMIs is supported by NGOs, and some part of the HMIs is also supported by the government. But it's kind of a new trend and a new initiative, so it's kind of mixed. I can say that.
So there's no one organization who manages the information in Ethiopia. It's being managed by different entities, sometimes using an online system, or I don't think HMIS is predominantly online, but it's like computer based. And then there is manual system as well. So it's a mixed approach. Okay.
Yes.
Yeah. And do you know of any challenges because of that, because it's a mixed approach?
Yeah, actually there's a lot of challenges in LMIs in Ethiopia. There's data error, there's irregularity of reporting. Actually, when some organization leave, or when some project phase out, the data, the system, all the LMIS system phase out with the organization. There's a problem of sustainability, I can say that.
Okay.
And the data are always new, especially this forecasting, consumption.
You got muted, sorry.
Sorry, how about now?
Yes.
Okay, so the main challenge is the data are not regular, and also they are not taken by the Ministry of Health at the heart of the supply chain.
Yes. Okay. All right. Wilson, you had unmuted yourself, I guess. Can go on.
Right. In Zimbabwe, the information is managed by NatFarm, but with the help of donors. I think in about 2008, thereabout, US Deliver Project, they did a pilot program called Zimbabwe Assisted Pool System, which then created an electronic logistics management information system. But however, sometimes it's done online, sometimes it's offline. So when it's inputted online, offline, when then they come back online, they do it. But it's not 100% foolproof. I was made to understand that UNICEF, they contracted somebody, I think, is it India or Pakistan, who is actually going to do a comprehensive new system, which will include even the health centers, the clinics themselves. If they dispense products, the system is
Wilson,
so they are working on that system, but so far it has got a lot of changes. Hence, there is expiration of products, a lot of prefer. I don't know if you heard the last part.
Yes, we did.
Thank you very much.
Yes. So, Wilson, do you know if this is only for vaccines, or is this for all products that this new system is being created?
It is for all products. UNICEF in Zimbabwe, they don't primarily manage the EPI, Extended Program for Immunization, but rather they are also the administrators of the Health Development Fund. So their program cut across not only vaccines, but even essential medicines. Even strengthening the supply chain is also the responsibility of UNICEF. So it will improve products.
Okay. Abdul is writing that in Benin, all information, it is sent to Kame, and they make the deliveries according to that demand. They have these trimestral meetings to gather the information shared from each medical health center. And then they surely have an integrated information system which led them to centralized and well manage the information. Okay, excellent. So in this session, what we're trying to discuss predominantly were these three flows. But then when we talk about these three flows, products, information, and funds, we also need to understand how supply chain is structured, how it is governed, what are those factors that influences governance of supply chain, like the administrative systems, the presence of donors, presence of private sector. So all these things, they influence governance and the structure of supply chain in the country, which eventually influences the flow of products, information, and finances. Now, in the module 2 of week 1, there is an assignment for all of you where you have to sketch the supply chain structure of your country, clearly indicating these three flows. So how the flow of product is happening from the supplier to the consumer or patient, how the information is flowing from one place to the other, and how the funds are moving from one place to the other. Once you do that, we believe that you will have a much better understanding of your own of the supply chain of your own country, and we will share all those sketches with everyone on the group, so you can also look at the supply chain structures of other countries as well. Okay, so with this, this is the end of today's session. If there are any other questions, please, we are happy to hear. Otherwise, I'm just quickly going to launch the feedback poll, and while if there are any other questions I can answer, it would be good to understand your feedback of today's session. And again, I would like to apologize on Gilles' behalf. He's busy in some family issue, and he will be back here in the next week's session, which is on quantification forecasting. Okay. So thank you so much for giving us excellent ratings. This really helps us, bring this course, these materials to you with the high motivation. In each modules as well, there are these small feedback at the end of each module. So please also fill those. We do look at those feedbacks very seriously. And in case you have any more feedback which you want to share anytime, either on emails during these sessions or on the platform itself, please do that. We take feedback very seriously. This is the third cohort, and we're also running the courses in French. So we keep on improving the course each time because of the feedback that people give us. Okay. So with that, I would like to thank you again for attending this session. And I hope you find the course interesting on the platform. Do contribute to the discussions, because that is one of the major portion of this course, where you can learn from the experiences of your colleagues. You can also, just like Facebook and LinkedIn, connect with all the colleagues. There is a feature where you can connect with each other. You can also do private chat. You can also build your network on the platform as well. Okay, so with that, I bid you goodbye for today. The recordings will be shared on the platform itself once we download them, or you can also download it directly from the group. If you go to the Zoom tab on the group, you will be able to download these recordings if you wish. Okay, is there any other question you can still ask? Otherwise, I will just stop the recording, and then we'll end this session.